Hey, Jane? Jane?
I'm ready to rock and roll. Do you want to use the computer to go to the next slide?
That'll be
Would you
fine.
rather use?
Then I'm just. Ready?
Yeah.
Morning. Morning. Let's go up. Good. Do you mind if I take 2 minutes at the beginning to we'll talk about the nascent panel and leave an option for people to ask you questions about it?
Oh, sure.
Yeah, great. Thank you. We have to go to Kelly. Right, we have to go to Kelly, Kansas. No. You're home in Hawaii? No, I lived there for about 20 years. Good place to go to school. Was that a while before you did that? I go to school there from somewhere else, or did you? Yeah. Just traveling around in London. Okay, we'll get started. So our speaker today is Dr. Meredith Kilgore. Dr. Kilgore is professor and chair of the Department of Healthcare Organization and Policy in the School of Public Health. He has been a very strong participant in this program for many years. He's particularly interested in how decisions are made in public health policy, taking into account financial aspects of the decision as well as other aspects. I just want to mention one of the things that he's been a leader in for several years here at UAB. So I think I may have mentioned this earlier in our meetings, but Dr. Kilgore and Paul Sanders in the Renal Division of the Department of Medicine are the co-leaders of a program called the Nascent Project Panel, which is an opportunity for people really at any career stage, but particularly at your level, to speak before a group of 5 to 8 experts in a broad range of translational research. It includes 2 leaders, a biostatistician, an epidemiologist, an informaticist, someone with experience in getting how the IRB works, someone who's an expert in how the IACUC works, and then some content experts in your own area to talk about the research program you're developing and to give you advice on ways to really frame it most effectively going forward so that you'll be competitive to write a grant down the road. It's great if you have some idea of what your specific aims of your project really are, how they're developing. It's a really great opportunity to get to test your ideas with a friendly group at home who can help you, give you the perspective of what people who might be on the study section who aren't probably the people who will be reviewing your grant, because we're probably not the perfect content experts for what you're doing, but who will be able to tell whether you're framing what you're doing in a way that really grabs the attention and elicits confidence from a group of people who are going to have to make a judgment about your work. So this group meets once a month on Wednesday at 4 p.m. Jean Lambert and I help coordinate some aspects of it. I'm happy to talk to you ahead of time if you think you might want to participate. Usually there are 2 people who present in an hour-and-a-half period, so you have about 15 minutes to talk about your work and 20 to 30 minutes for a discussion of where you're going and how it could possibly be framed more effectively. It's really been found by a lot of people to be very, very useful. And it's useful maybe to talk to me or Jean or
He's not standing
before.
He's not standing on the podium?
Speak at the
Okay.
session to be sure that you're planning to take advantage of it and that you're planning to use your time most effectively. But I really urge you to think about it. It's really a great opportunity. It's a really unique program here at UAB that I haven't heard a very similar thing at any other institution, and it's been extremely helpful for people who are heading towards writing a K award or something like that. But it can, if you're already at the point where you're getting ready to write your first art grant or a foundation grant, it can be very helpful in that setting as well. And even for people who are really just have career choices that are pretty significant in terms of how you're going to direct your academic career, it doesn't always have to be focused on a grant, although that's sort of the easiest model to follow. But we'd be happy to talk to you about any of those things. So it's the fourth Thursday, our fourth Wednesday of the month. That happens here at 4 o'clock. So, but you have to sign up in advance. We'll schedule you, and we could set it up at any time from us. Okay, thanks, Meredith.
Certainly. So, good morning. This works best when it's sort of a conversation. So the idea is if something is confusing or silly, stop me and say, that's confusing or silly. And I'm fine with that. What I want to do is get some basic motivation for what we're about in doing economic evaluations. Why do we do them at all? Different approaches, then the specific techniques for framing decisions, and cost effectiveness analysis is just a decision analysis with multiple objectives. You want to maximize health, minimize cost, so you've got competing objectives there. Talk about how cost-effective ratios are evaluated and cover some examples. If I don't get through everything, that's fine. So the basic things that we want to think about is we're dealing with uncertainty, uncertain risks, uncertain outcomes, and we have to make choices about what to do, and we're also faced with limited resources. That's all piles in to make decision-making challenging. So uncertainty, we often don't know what exactly it is that we're dealing with. We're talking about a clinical issue. You're presented with constellations of signs and symptoms, right? And you go, well, I have some idea of what the probability is of what I'm dealing with. It's more likely to be X or Y. And you can obtain more information, but the information is seldom perfect information. Right? We have tests that have less than perfect sensitivity and specificity, or if they're typically the tests that are quite perfect come with their own risks. Think of cardiac catheterization, that sort of thing. We don't just all go out and do that because just in case. The next thing that we're uncertain about is what will happen given a treatment option in a certain, so assume we have the disease right, we still don't know how this individual will respond to treatment. There's some probability of benefit, some cure or improvement in symptoms or something like that. There's also some probability of adverse outcomes. Most treatments have both upsides and downsides. So why do these sort of evaluations? The need to make choices, and the sort of choices we face are to treat someone or not, and what treatment to use. Larger scale, what sort of facilities to fund? What do I want to build so that I'm able to deliver? What programs do I want to put into place? Bigger picture, what things do I want to study to answer these other questions? Where do I want to invest resources in terms of research in order to inform all these other decisions? And why do we do this in healthcare in particular? Healthcare isn't the only place you see these sort of evaluations, but it's not in general rule, right? Most of the decisions that we make in the world do not involve a structured formal decision analysis. So why in healthcare? Let me see if I do this. Let me go back. Why would you think it was, what's different about healthcare?
We spend a ton of money on it. We spend a lot of money on health.
We do spend a lot of money on it. We spend a lot of money on houses and cars, but I usually don't have somebody show up and say, well, I'm choosing between these two houses and I need an economist to come and assess the value of them. How do you get an idea of what the value of a house is?
Something that society pays for.
You've got comparable houses around. You've got a market for houses. Now, houses is a kind of sticky one because it's a big purchase. There are a bunch of uncertainties there, and you do more research in buying a house than in buying a car than in buying a toothpaste.
Well, I think one of the biggest differences in healthcare is that the end result isn't a tangible thing. It's somebody's life, it's somebody's health, it's somebody's quality of life. And so you can't really put a price on that. Like, how much is that worth?
And that's a really excellent question. And how do we put prices on most things?
Supply and demand.
That's right. And in the market, there's a market, right? Well, there's a market for healthcare, but who pays for it? Government, insurance companies, employers. Very seldom they compete. It's like nobody goes out and buys me a car. And, oh, I need a car. Well, I don't have car insurance that says, oh, well, we'll make sure you have a car, right? First, I get the car. And so I pick the car based on what I'm willing to spend on a car, and what I'm willing to spend determines what kind of car I can get. Okay, all right, so we do that. And that's how we allocate all kinds of resources, food, housing, shelter, clothing, all the kind of stuff that's just as necessary for life and health as healthcare, but it gets allocated in the market, right? Healthcare is, has a whole bunch of bundle of things that make it wonderful for an economist to study because it violates every assumption we make about markets, right? Somebody else pays for it, right? The person consuming it often is not as well informed as the provider as to what, basically spend a lot of time and training to understand disease processes and treatments and outcomes and this sort of stuff that most patients, they're just going to have to defer to your judgment, right? There's a conversation about values and what you want to accomplish and what sort of trade-offs there are, but here you've got unequal information, right? And I have unequal information between the person paying for my health care and me. I know what sort of health care I'm liable to consume. I know what habits that I engage in that either promote or detract from my health. So that sort of stuff. So that makes it unequal information there. There's also what economists refer to as externalities. Here's where I think about a flu shot. I'm willing to pay a certain amount for a flu shot so that I don't get the flu, right? But that doesn't capture the value of the flu shot, because if I get a flu shot, I can't give you the flu. Or are you willing to pay me to get a flu shot, right? So it's going, okay, well, as a society, if we just let a market work, there's going to be value that's not captured. So anyway, those are some of the things. Then the other problem is scarcity, limited resources, unlimited wants. There's opportunity cost, and this is a key concept that I want to get at. It's very specific. What the cost of something is what you have to give up in order to get it, right? Think about what you might prefer to do if you weren't sitting here listening to me yammer away, right? So that's what you're giving up, right? Whatever it would be, watching TV, getting a little extra sleep, reading something you need to study for another situation, whatever it is, whatever the next best use of your time would be, you've chosen to be here, right? So you've given up whatever the next best thing is, but that's what the cost is, right? It's not some hypothetical, what you would be willing to pay to come here or whatever like that. It's what in concrete you gave up. So here's the old standard textbook. Economics is it's the study of choices. It's not the study of money. We have different disciplines that study money in different ways. Economics touches on money, but the first half of my microeconomic analysis class, we were not allowed to refer to money in any way, shape, or form. It was all goods, products, either goods for consumption or production, this sort of thing. We studied production functions. Alternate definition, you can't always get what you want. Didn't quite finish this degree, but did okay anyway. So I do want to talk about, if you want to be impress your economist friends, then you'll know the different flavors of evaluation. There's one thing that I've left off here, which is just a cost analysis. If we're not terribly concerned with the outcome, I'm just trying to be most efficient in accomplishing something, and I just want to save money, then I can do that. It's legitimate to sometimes just look at money. But typically, when we're doing an economic evaluation, we're looking at the value of something in relation to its cost, okay? And that comes in different flavors. Technically, cost effectiveness analysis, which is a term that gets bandied around and used more broadly than it technically is dollars per life saved, per life years gained. The denominator, the measure of effectiveness, is something that can be objectively measured, right? People at blood pressure target, right? Cancer screening, what does it cost to detect another case, right? Things that we can all count and agree on. That cost effectiveness analysis. So years of life, that's fine. I know what life expectancy is. I can estimate all these things. Cost utility analysis is what's the value of an improvement in health? That was the question that you raised, which is a really difficult one. And I'll try to get at an answer to it down the road. But here you see dollars per quality adjusted life year. That's typically what I use if I'm doing cost utility analysis. World Health Organization uses something called disability adjusted life years, which is just quality adjusted life years turned on its head. Quality adjusted life years is a measure of health. Disability adjusted life years is a measure of suffering, right? We want to minimize damage. It's like, what does it cost to get rid of disability adjusted life year and add a year of health? So they're just reverse mirror images of each other. In cost benefit analysis, it's all money. It's what's the net benefit in terms of dollars, and we put a dollar amount on improvements in health or life saved, or basically there's a concept of the value of a statistical life, right? What's the value that we put on if we have a program? You don't see that in healthcare very much. In occupational health and safety, in all kind of regulatory environments, environmental protection agency. Anytime you do rules, regulations that affect business and impose costs on people, the federal law requires them to do a cost-benefit analysis that says, okay, what's the benefit in terms of improved health and life, and what is the cost in terms of additional cost? What does it cost to put proper seat belts in all the cars, right? What's it cost to require everybody with a kid to buy an infant seat and make it sure it fits and do all that? New grandfathers, so have to do some of that. In healthcare, we don't do that, mostly because it's considered tacky to put a dollar value on life, right? But at some point, you have to say, what is it worth? That's still the question that comes up. So you can't really duck it forever. So when we're assessing things that we do in healthcare or public health, we look first at controlled trials. And that gives us a measure of efficacy. That says when something's done in a carefully controlled environment with carefully selected participants, provided by people that are expert in this area of treatment, what happens, right? Big, nice, randomized controlled trial where we make sure we follow up everybody, we assure compliance, we measure things carefully, have protocols. That's great, okay? So that's really good at getting at the idea that there's a lot of really bright ideas that didn't pan out, right? I think 1 in 5 compounds that goes into phase 3 trials makes it out, something like that. So the next question is what happens in the real world? What happens when it's your typical physician and who's got 15 minutes to talk to the person, and the person that, sort of takes their pills some of the time, and, what happens then, right? So that's effectiveness, right? You can have a drug that's very effective, but has unpleasant side effects, and some people don't take it. Then, it could be very efficacious, but not very effective, right? And then the bottom line is it worth the cost? Back in the day, when we were first doing clot busting for ischemia, we used TPA, tissue plasminogen activator. No, we used streptokinase. Very cheap, old thing, and it worked. Then TPA came out, and they said, be careful with, I worked at Kaiser Permanente then, they said, be careful with this medicine, that each of those vials cost $2,000, right? And so that was 10 times as much as the streptokinase, and I was going, it occurred to me at the time, well, is it really 10 times as good? I don't know, so it's better. So, but that becomes a question. Then, and when you're addressing that question, the perspective matters a lot, particularly who pays, but who gains as well. What's the total? So, and I will get into that. So, according to the gold standard, which is the text, Cost Effectiveness in Health and Medicine, the U.S. Public Health Service Consensus Panel statement on this came out in 1996. And the reason it's the gold standard is Martha Gold was the editor, and it's sort of a yellowish book. But it says all cost effectiveness analysis should be taken from the societal perspective. We should consider all the costs and benefits, no matter who pays, everything that goes in, everything should go into the equation. Then you can compare measles vaccine with cabbage, right? I'm capturing everything that goes into producing those things, all the value and all the cost, then voila. The problem is, in most places, there's nobody that makes decisions from society's perspective, unless you have a benevolent dictator. There are people that take decisions that they're supposed to take from their point of view, and that's not illegitimate. So it may be a government agency. So we do a lot of work for the All Kids program here and for Alabama Medicaid, trying to establish, please, it's not a good idea to just cut money out of that, so it's going to cost you more in the long run, especially when the federal government's kicking in. Anyway, all those sort of questions. So there's a government agency perspective, right? There's an insurer perspective. Blue Cross has to decide what to cover, what sort of co-pays, what tier to put the drug in, all these sort of things. Now, they get accused of only caring about money. Well, I can sell you insurance that has a $100,000 deductible and a 90% copay, right? And I don't think you're going to buy that product. So particularly if I exclude all hospitalization, except at small rural hospitals. So in other words, an insurance product has to have value in it. So they have to weigh the value against the cost. If I cover this treatment for everybody or for people, what's it cost in terms of increase in premiums? Because I'm going to have to do that. So that balancing act has to take place. The deal with insurers is they tend to have a short timeline. 5 years is a long time for Blue Cross, right? So if I have a really great treatment that prevents something happening 20 years from now, they would tend to discount it. There's a hospital or physician perspective. What does it cost me to deliver a service, and what do I get paid for? Patient-family perspective. What do they care about? They care what Blue Cross has to pay for their hospitalization? No. Not really. A little bit. They know it affects their premiums, but they care what they have to pay out of pocket. They care how much time they have to spend, what missed work, all that sort of stuff. Informal caregiving, how much time do you have to take off to take care of the kid or to take care of mom, this sort of thing. And that sounds like, oh, okay, well, that's sort of on the fringes of things. Actually, if you look where I look, I do a lot of work in long-term care. The amount of informal care, however you value it, is probably more than 4 times the whole Medicaid program. That's why it's really hard to do these home and community-based services, because there's so many people getting free care that if you start paying for it, they're going to start, oh, okay, well, I'll take some of that. So that's what makes that different. Anyway, I try to frame analyses that I do with a view toward influencing decision makers that I want to influence. So that tends to make the work a little more relevant. So all of these perspectives are valid. If you don't take the patient perspective into account, then you don't get good persistence with therapies that are expensive or uncomfortable if they don't understand the benefit, right? If I don't convince the insurer that this is value for money, that people are going to want this in that product, and it's going to be affordable to them, all right. So now we have a framework that allows us to approach these, sort of bring all this stuff together, and it's called decision analysis. I trained at the Grand Corporation. This came out in World War II. Lots of, competing objectives. How do we allocate resources here and there? How do we, how can we break things and kill people most efficiently? Because you want to do that, you want to get the war over with. So this started there and turned out to have applications all over the place, but particularly in healthcare. So it's a formal framework for evaluating choices. That assumes we want to maximize expected values, whatever we consider good, or minimize expected costs or harms or whatever. So everything is either positive or negative. And with a straight decision analysis problem, we're only caring about one dimension, right? We do this with decision trees. So you have a problem, and a problem means I have choices. If I have a situation that's unpleasant, but there's nothing I can do about it, I don't have a problem, I have a circumstance, right? I may not like the gravitational constant, right? It gets to my knees. But I can't go I don't have a choice about that. I can't go get a different gravity. I can't even go someplace with some planet with less mass, right? Which would be helpful, but there's nothing I can do about that. Something, but if I have a choice, I do this or that, well, then I have a problem. I have to decide, okay? If I make one choice, there's a probability that something nice will happen, and I'll get some good payoff from that, so I'll benefit. There's also a probability that something bad might happen, or something good fail to happen, and I get a bad payoff, right? The payoffs can be anything you want. they all have to be the same thing at the end of the day, right? Here is a real simple example of the decision analysis. You have a choice, and I'll give you this choice right now. I can toss a coin, and if it comes up heads, I'll give you $1. If it comes up tails, you give me $1. Your choice is to do that or not. Who wants to play? All right. What if I say it's $1,000? You'll win $1,000 or lose $1,000. It's the same expected value, right? The expected payoff from either of these choices is 0. I can usually get somebody to play for $1 because that's better odds than you're going to get in any casino, right? That's certainly better than the lottery, whatever you can think of. That's even odds is pretty good. But we're risk averse. We care much more about losses than we do about gains. So we tend to want a better probability of good things happening in order for us to play. We'd rather stick with a bird in the hand sort of thing. So, example that I used back in the day, remember deal or no deal? So what you've got here is the expected value is the probability that you pick one of these numbers, right? It's going to be a random draw. You're going to pick one of these numbers. So the probability times the value is giving me an expected value of a little over 170,000, which is just the sum of all these numbers divided by 5. There's some guy offering you 150,000 to go away, right? Don't play this game anymore, right? And I'll take the 150,000. That's for sure. I might have 500,000 coming my way, but I also might have $5. So that's a good way to get at this risk aversion, the expected value versus what the value is on the gamble, right? Here's one that we have played before. We think it's appendicitis, right? Do we do surgery? If we do surgery, there's some operative mortality, right? If we don't do surgery, if they don't have appendicitis, then, well, they'll get over it. And if they do have appendicitis, there's some probability they'll die from that, right? Now, appendicitis was bad enough that even before antibiotics and anesthetics, people decided to do the surgery, right? Now we're a lot better at figuring out what it is and a lot better at doing surgery than we were, so it's much more likely that you're going to get it out if it's a problem. Now I don't have any more just this issue. I don't have just this choice. I have another choice. I can go get some more information, right? I can do a test. I can get a CAT scan or whatever I would do. And if the person has appendicitis, there's some probability that they're going to have a positive test result and I'll treat them, right? There's some probability they'll have a negative test result and they'll avoid and they won't get treated, right? Even though they have the disease. If they don't have the disease, the specificity of the test says what's the likelihood if you don't have the disease that you get a negative result and you don't get treated, right? And 1 minus that is the probability that you get a positive result even though you don't have the disease, right? This is a point that if you really get this, you'll understand that there are circumstances where more information can make you worse off, right? There's a very high probability you have appendicitis and you've got a crummy test, then you're better doing surgery than doing the test, right? Measuring costs. Again, prospective matters, treatment cost, have to include the cost of treating side effects. Everybody agrees about that. Related costs can be things like, if I'm treating somebody with warfarin, well, I have to count the cost of doing lab tests periodically to monitor the dose and adjust the dose as needed, right? If I'm treating somebody with warfarin, I have to consider that they might have a bleed that we have to treat, and that will cost something, but I might avoid a stroke, which is a substantial cost there, right? So all those related costs go in. The interesting thing is, all right, I put you on warfarin, we did not have a bleed, you did not have a stroke, and you got cancer. You didn't die from the stroke, so you got cancer. So do the cancer costs count? To an economist, they do, but very rarely do you see that actually put into anybody's analysis, right? You kind of have some level of cost that we just go, well, there's an average cost out there that we're not really affecting by this treatment, and it's okay to ignore it. And really what it is it's very hard to figure out all that, what the probability of everything else that could happen, and put that into the analysis. So this is a thing that I like to beat up on a little bit because it doesn't get done much. Why do patient-focused costs get ignored? With important exceptions, they're relatively small compared to the cost of care, particularly for big acute things, right? Going to the hospital, then the cost to the patient is a small fraction of the total cost of care, right? And if I'm a health system, from my point of view, it doesn't matter. It's like if I can get them out quicker, I don't care if that means the wife has to take off work to help take care of them for a couple of days. If I can get them out of the hospital and save money from the payer perspective and the provider perspective, that's all to the good. More attention is given to payers for direct medical cost because the decision makers about what to cover and what to pay and all that sort of stuff bear those costs, right? And the data on patient and family-centered costs are difficult to collect. It takes a study that I could do using Medicare claims that I could do. I could get the cost of care from a payer or a provider perspective, $150,000, something like that, and you say, oh no, I want all the patient costs in there too. I say, okay, well now you're at $250,000 or more. Because now I have to do surveys or have to collect those costs in some way, but they're not just sitting there for me to mine. Now, why are they important? The real cost to society, right? People are giving up something in order to get health care. Patient costs affect patient behavior. Use of preventive services, adherence with treatment, all that's affected by the burden that it imposes on the patient. And patient behaviors affect direct health care costs, right? So there's a consequence to not considering patient costs in the mix when we're doing this. The patient perspective cost, the pecuniary cost, that's what they pay out of pocket, which is co-payments and deductibles, co-insurance, but also travel costs, lost wages. Then there's waiting time, unpaid caregiver time, and stress. Just for example, people pay for Part A Medicare, most people pay no premiums. If you don't qualify for it, you can buy it. It costs $407 a month. $1,260 is the pay for a hospital stay of 1 to 60 days, then $350 per day. After that, up to 90 days, then $630, then you're on your own. 20 days free in the SNF if you do post-acute care. Then after that, it's $157 a day. Part B, $104.90 per month per premium. I think I looked that up last year, so it's pretty current. $147 deductible plus 20% coinsurance. Part D is really variable, hard to get. The basic standard benefit plan costs $38 a month. There's a $310 deductible, 25% copay, up to the donut hole. Then you're on your own for a while, and then you've got catastrophic coverage after that. The donut hole is going away under the Affordable Care Act, so that part's eroding. but that would mean premiums will have to rise. So to collect these data, you can use predetermined collection instruments and decide what you want to do. You can do recall. You can survey people and say, in the last 6 months, what have you spent out of pocket on this and that, right? Have people keep diaries or have people turn in receipts. So all of that imposes progressively more burden on people that are participants in the study, right? Typically, you need to compensate them for the burden you place. Other than, I did cover that. Informal caregiving, I mentioned that. So yeah, there's the actual number. The value of services that caregivers provide is estimated at something like $306 billion. Business loses $34 billion annually because employees caring for older adults. So that's measuring costs. So how do we measure effects? And these are all legitimate ways to measure effects. There's clinical endpoints, right? Blood sugar, hemoglobin A1C, what does it cost to get somebody to target? What does it cost to get somebody to target on cholesterol, blood pressure? Those are legitimate endpoints, right? If I'm comparing hypertension treatments, then I don't have to get at everything that's downstream from the blood pressure target. It's possible to go, okay, well, you prevent this many heart attacks, this many strokes, this much kidney failure, and what's the value of all that and everything like that. But I'm going, if I'm just comparing hypertension medicines, it's fine to just say, what does it cost to get somebody to target? Okay, using different approaches. Objective outcomes, infections avoided, right? Survival, either mortality in some period or actual survival, change in life expectancy. We can get at all of that, and that's cool. So all those are legitimate measures for different sorts of analyses. Then there's preferences. What do people really value? And that's where I would like to get back to a big picture and have a little side discussion. What things do we value in general? Good things. What makes things good? Yes.
Well, I saw a patient yesterday who lives in Mississippi, and her insurance covers breast augmentation, but does not cover any fertility care. So I thought that was an interesting statement on what's important to people in Mississippi.
And it would not be unusual to have plans that didn't cover either of those.
Correct.
But we value things that we want, right? And we disvalue or don't like things that we don't like. So we value health. We value stuff we can buy that we like to consume. Different people have different preferences, right? And different strengths of preferences, all that. Now, what do we value about health care? I'm not saving up for my MRI, looking forward to it, oh boy, once I can get there. A lot of healthcare is even unpleasant.
We want it to be available when we need it. We want it to be really available.
Yes, we want it now when we need it. We don't want it, and we want it not when we don't need it. That can be an interesting decision problem in itself. When do we need it? So we value healthcare for the health it produces, right? Either preventing illness or curing something, relieving symptoms. Definitely we like to stay alive longer, those sort of things. How do we value health? And here's where we get at the measure that we use typically here. How do I get to these quality adjusted life year things? And so I'll just say at this point, please suspend disbelief. I would say that we're imperfect. I'd say this is an important problem and the jury's out on how well we do it, okay? So first we're going to rate health states on a scale from 0 to 1, where 0 is equivalent to death and 1 is equivalent to well. That leaves us with some interesting questions. Are these fixed points, or are there health states worse than 0? Are there negative health states? That's a philosophical question, right? There are at least 2 states now that recognize de jure that there are health states worse than death because they allow you to kill yourself. So, and there's folks, I worked in the ICU before Cruzon, and what was the other big case? When I first worked in the intensive care unit, it was considered negligent homicide not to intubate someone, no matter how much they were screaming, "Leave me alone." It was horrible. People were tortured to death, it was like, and everybody knew they were dying. So that's where you got the slow code. Code 500, please bring the crash. So you have to go through the motions, But then they had some court cases that says, oh, it's okay for people to refuse treatment. Oh, what a novel thing. So anyway, so that was basically, so I've witnessed health states that I've contributed to that I didn't appreciate and felt like they were, it was better off if I was not doing what I was doing. The other one is, are health states better than well? And that depends on what's well, right? The World Health Organization defines well as all your Maslow's hierarchy of needs are met, right? Self-actualized nirvana, right? Complete mental, physical well-being. That's it. Anything less than that is a problem. I think that the appendectomy is not going to bring you, universal peace. So I think that's a bit much demand from the healthcare system. I've got a definition of wellness that I like, which is I'm well if I don't put any attention on my health. It ain't bothering me, which I think is good enough, and I think that's what most people would be satisfied with. If I can get rid of what's bothering me, then you've done your job. Thank you very much. If I can avoid something bothering me in the future, that's also another nice thing, Public health, we think along those lines. Are there states better than well? Well, I grew up in the 60s, early 70s. Lots of people believe that our health state's much better than well. So anyway, believe that for other philosophical debates. But so that's what we've got is this measure. And so we've got the cost effectiveness module, treat or don't treat. You get better or you don't, right? And then you get some payoffs in terms of quality adjusted life years. Let me see. I thought I talked about how we get there. How do we measure these? How do we put somebody on the scale? And typically we'll do something called a standard gamble. And I'll say, you've got chronic pain. You have a choice. You can just keep your chronic pain, or I've got a magic pill, right? And it will cure your pain. Total pain goes away, right? Problem is, some people are allergic to this pill and they die right away. So what's the probability of survival and cure, the minimal probability that you would accept in order to want to do this treatment, right? Or conversely, what's the maximum risk of death, right? Now, some people in severe enough chronic pain will tell you, just give me the pill. I'm not going to worry about the probabilities. It's like, give me the pill, even if it's 100% fatal. Chronic pain is a good example of something we don't deal with very well. But anyway, so we do stuff like that. Or we say, you're going to live 20 years with chronic pain. How many years would you give up to be rid of that pain, right? So if they say 15, and 15 divided by 20, their quality of life is 0.75, So we have ways of getting at this. How well we get at it, I think, is still an issue. So then we put them into these models, And we wind up at the end of the day with the ratio of cost to effects. And we considered what are the units that we're going to use for effectiveness, what are the costs we're going to consider. We've done all of that. And at the end of the day, we're left with this ratio. And this ratio falls on this plane somewhere, right? There's things that are either add to costs or save money. They either cost money or save money or do nothing. They either improve health or make people worse off, right? Now, what about these things up here, that interventions that are less effective and cost more than the alternative, right? Those are said to be dominated. And the decision falling out of that analysis is stop it. Don't do that. You can make everyone better off by not doing that, right? And save money. On the other hand, in this other quadrant here, this makes people better off and saves money. Okay, well, try to find those things. There are things like that. Aspirin after an MI. Hands down, it's like very cheap, very effective, prevents other costs, all kind of good stuff. The problem where you have to consider the question of value is it costs more money to improve health, right? Or at some detriment to health, we can save a lot of money, right? And those are just mirror images that I can just flip the decision problem around and get either of these quadrants to be. But that's where you have to say, well, what's the threshold? What's the value of improved health that I'm going to say this is worth it or it isn't? Now, I want to push on, when we're comparing treatments, a lot of times you'll get a whole bunch of treatments compared with doing nothing, right? That doesn't get at the opportunity cost. The opportunity cost is what you don't get because you got this, right? So we generally compare treatments with either the next most effective or the next most costly, right? And it doesn't matter which rank order you use. So you get what's called an incremental cost effectiveness ratio, which is what's the cost of treatment 1 minus the cost of treatment 2 divided by the difference in effectiveness of the two. And here's an illustration of if I have some magical threshold of $50,000 per quality adjusted life year, and I say that's what's worthwhile, and I want to compare these two treatments, and these are both treatments with the same drug, right? One is 20 milligrams, say, of atorvastatin versus 40 milligrams of atorvastatin. But I don't know which statin it is. Could be pravastatin. So this is an old example. Consider, so the cost per life year was $16,000 was the added cost of putting somebody on that, and you gain 0.4 life years. So the cost is $40,000 per life year. And if you doubled the dose, the cost didn't double, but it went up considerably, $27,000, and you got more health effect. Now the cost effectiveness ratio is $45,000, still affordable, okay? But that's not the opportunity cost of using 40 milligrams. If I use 40 milligrams, what I'm really giving up is using 20 milligrams, right? So comparing 40 with nothing misses the fact that I have an alternative, which is a lower dose, which is cheaper. So what I want to do is look at the difference, 27,000 minus 16,000, and the difference in effectiveness, which is 0.2 life years. So now I'm at 55,000. Oh, that's more than I'm willing to pay. So, and those are all just arbitrary hypothetical numbers. But that's why you want to do these incremental. I'm going to walk you through, and I love old examples. This is before HART, when HIV was fatal, and all we were interested in was preventing opportunistic infections. So there were a whole bunch of regimens you could put people on to prevent infections, or you could not do anything. So these are just all different drug combinations. So then I just assign them numbers, And after that, I don't even worry about what the combinations are. I just want to know what they cost and what the health effect is, right? How many, and these are quality adjusted life months. So in other words, somebody taking strategy 1, which was to do nothing, would net you 39 quality adjusted life months. Strategy 9 was the most expensive and would net you 44.6 quality adjusted life months. Okay?
But how do you get that cost of nothing?
Because if you get the infection, we're going to treat it. It's, really doing nothing is, if doing nothing is really an option, sometimes some places, then it has 0 cost. But here we're actually going to treat the infections if they happen. That's an excellent point. So then what I do first is plot these things, plot the effectiveness against the cost, and you'll see that there are some things that stand out as being perhaps bad ideas. If you look at 8 compared with 5, it costs much more and produces less health benefit. Same thing with 4 compared with 3, 8 compared with 7. They're either equal, more costly and equal, or less. And if I line them up and highlight them like that, you can see, well, these are things that I just would not do, right? So if I throw those things out, then I get a cleaner looking graph, right? I still have one strategy that looks a little peculiar. What you want is a convex curve. To get more health, I have to pay more per unit of health. With 7, it's concave. That means some combination of 5 and 9 will always dominate 7. Okay, that's called weak dominance. And you can get that from looking at the incremental cost effectiveness ratios. 7 has a much higher cost effectiveness ratio than either of its neighbors. If I can throw out 7, throwing out 7 means I've got to do some way of allocating treatment 5 and treatment 9 to different, first come, first serve, gets 9 until we're out of money and now you're just stuck with 5, or we do a lottery, or, it might be politically unfeasible to leave 7 out. But anyway, if we can throw 7 out, then now we wind up with ever increasing cost per additional health, and a pretty graph, and a satisfied economist that says, my job has been well done. And you're sort of still left with, what do I want to do? And that depends on where you draw the line. So I've converted these into the more familiar cost per quality. And so they range from, you used to hear 25 to 50 or 30 to 60,000 was a good price range. Those numbers didn't change for like 20 years. It's just nice big round numbers. In the UK, actually 30,000 pounds per life year is the threshold, with some exceptions, orphan drugs, this sort of thing. But basically, they've got a National Institute for Clinical Excellence, which is nice. So they have a nice way of doing things, and the nice way is to say the threshold is 30,000 pounds. Here, usually the treatment that gets beat up on the most is neonatal intensive care, because it produces often poor health outcomes at very high costs. So those tend to run 250,000 per quality, something like that. So in other words, we're willing to spend a bunch of money here. So and if you do value statistical life, that's, if you go to the cost benefit literature and say, what value do we put on life here? It's about $3 million per statistical life, which if you go, what's the life expectancy of a working person, then that, gets into the $250,000, $300,000 per year.
What about adjusting the quality, adjust the life months or life years as a proportion of how much life expectancy remains?
Oh, you definitely do that. It's quality times duration.
You know, so adding 0.6 life years for somebody, like with a statin, that's gonna live for 30 more years, how much more valuable is that than somebody toward the end of life, where you could add a month, but it could be a much greater percentage of the remaining.
What we typically do is apply a discount rate, which is, I'd rather have, it's easy to think of with money. I'd rather have money now than 20 years from now, right? And we do that all the time. It's like, if I want money 20 years from now, then I put it in the bank, I loan it to the bank pays me for doing that, not much, right? If I want something now, then I can borrow money, right? But I have to pay interest on that. So, and we've got markets for that. We do that with money all the time. That's not a problem. It's a little funnier to do that with life, right? But if I don't do some sort of adjustment like that, then things get out of whack, right? It makes a life year 30 years from now look like the same as a life year now, which, you know, and I'd rather you save my life now than 30 years from now.
Yeah.
So,
Because you probably pay a lot for, if I were going to die in a year, I'd pay a lot for a month more of life than I would a month each life year.
and typically what you're looking at with statins is you're averaging over a population. So there are a bunch of people that don't die of an MI that would have, and that's where you save them. You know, it's like, so that they all get a yes or no, and then they get a bunch of years. So it's not typically somebody really gets 0.6.
Yeah.
Your question?
I'm kind of along the same line, but I'm confused about what exactly is a quality adjusted life year. Like, does that take account whether the person is a productive member of society at all and the cost of that? Like, I mean, if you produce somebody who can go back to work and versus maybe a NICU baby that never works even later on. I mean,
This is where perspective comes in. One of my mentors, Emmett Keeler, a mathematician at Rand, looked at the cost of tobacco, particularly cigarette smoking. So when you factor in the taxes and the money they don't collect in Social Security, then you would really want to encourage people to smoke. Because basically, yes, there's healthcare costs, but they're totally swamped by all the savings from other things. So if all you cared about was money, then you would encourage people to smoke. You know, smoke them if you got them, put them in the K rations or whatever it was. So anyway, we doing good on time? It's like I'm glossing over a lot of things here that can be folded in or can be set aside intentionally, depending on what you're trying to do. Here we're just going, a life year is a life year, and it has a health quality to it, regardless if it's a 70-year-old or a newborn, right? Now, a newborn does get a much more life expectancy than a 70-year-old. So if I save a newborn life, I'm typically generating a lot more life years than if I save a 70-year-old life. So that gets accounted that way. But when
you say quality adjusted life years, that is taking into account the health quality?
That's health quality. And the consensus panel felt like that got at productivity as well. That if you tried to count in wages and those sort of things, that you would sort of be double counting. I don't necessarily agree with that. And if I'm taking it from an employer perspective, who's one of the big payers, then if you look at lost productivity, that's something that they definitely would want to factor in. So that's what I'm saying. It matters what's the real question you're trying to get at. And so a lot of this can get rather involved.
I was thinking, because we mentioned fertility earlier, how would you even do a quality cost of fertility?
All right, now you're throwing me back into, you're saying I have to be honest now.
Yeah.
So I'm trained as an economist, and what I really think is the bottom line is willingness to pay. And I can get at what's the value of in vitro, because a lot of people buy it. If they don't have coverage, or they have, maybe one round is covered and then you're on your own. So I know what people are willing to pay out of pocket for cosmetic surgeries. I know what people are willing to pay out of pocket. If they're not covered, it's like, so there's a bunch of things. I always thought,
I guess like the societal cost, higher up perspective.
But I think what a lot of economists would say, we should really be doing cost-benefit analysis. We should be doing willingness to pay, because that's what you're really doing when you're saying, well, what's the threshold value above which I'm going to say it's not worth the extra cost, right? There has to be willingness to pay stuck in there somewhere. You might as well be explicit about it. But that means getting back to putting a dollar value on life and health. And so that can be an interesting fraud issue. Now we're dealing with another level of uncertainty. So I produced all these numbers, right? All these expected values and costs and all this that we knew with perfect precision, right? I know what the sensitivity and specificity of the test are. I know what the life expectancy will be, I know what the probability of disease is. And I don't know any of these. None of this comes in the big book of probabilities. We go out and we estimate these things the best we can, and we're left with residual uncertainty in the models. What we typically do in science is hypothesis testing, yes? Everybody's had some biostats, something like that? Had seen p-values in the journals and sort of things. It's not a bad practice. It's not something I disparage too much, but I go, I always have a student that's looking at the difference in two treatments and saying, is that really statistically significant difference? And I go, oh, you thought we were doing science. We're doing decision analysis. We have to make a choice. So I'm not going to throw out all the information I have because P is 0.06. I'm going to worry about the uncertainty, but my hypothesis, just saying, well, okay, well, I'll do a bigger trial. Well, that's going to cost money, right? So something comes in here that's not exactly that. So we've done a lot of sensitivity analysis for a long time, and you even see that in mainstream literature and this sort of stuff. And we do also what's called value information analysis. And I'm going to walk through some of this, I think. Yes. Hypothesis testing. The first problem you run into is calculating standard errors for ratios. Even if you have nice, normally distributed data for costs and health outcomes, and I guarantee you do not, then the ratio of two normal distributions is a Cauchy distribution, that means to people in real analysis, I have a probability distribution that has no solution. I can't define, at any point I can't define what the probability is. We can guesstimate it, but we're usually way off. So these things are fiendishly difficult to deal with. A lot of people have tried for a long time, and nothing's satisfactory. There's even a lovely article that came out called The Irrelevancy of Inference, which says decisions have to be made on the best available data, right? It may be crummy data, but if that's all you've got, level 3 data, expert opinion, this is the thing I think you should do, because I'm well trained. I know stuff. Believe me. That's not great evidence, but that's, if that's the best I've got, well, that's the best I've got. I might try to do better. If that's all I know is what I think is the best thing, I know that that's, not very reliable, but I'm still going to do whatever I think is the best thing until I've done something to So we do sensitivity analysis. The purpose of sensitivity analysis is saying, how far off do we think we might be, right? And we do one-way analysis by everything in one of these decision trees, every probability, every cost, every estimate of effect gets varied, holding everything else constant, to see how that changes the cost effectiveness ratio. Some things, you can vary them a whole lot and it really doesn't matter, right? The cost of an extremely improbable event can vary a whole lot and not change the bottom line very much. I did stuff on autologous blood transfusion after a heart surgery, right? And there's the cost of complications, either transfusion reactions or infections or whatever like that. And some of those have tremendous costs. But the probabilities are so low given current blood banking that, you know, it didn't matter. You could vary those costs by 2 standard deviations and it didn't change anything. On the other hand, if I'm doing screening for cancer, a % change in the prevalence of disease can have a profound effect on the cost effectiveness of screening. So anyway, so you say, that tells me what's important. What are the things that, if I want to narrow the uncertainty, what are the things that I need to measure most carefully, right? Then you do scenario analysis, which is, I'm going to set every probability in favor of one treatment or another, and then every probability against that treatment, right? And say, if the world is as bad as it can be or as good as it can be, how much does that change my decision? If that doesn't change my choice, then I'm going, that's pretty robust finding. That happens sometimes. Usually it goes, the world is not as good or as bad as it could be. You know, everything's not extreme. So then you do some sort of simulation. If I have a bunch of data, I can do what's called bootstrapping, which is resampling the data many times. Draw a new sample with replacement from all the people, and so I can mimic the distribution in the real world that way. Or if I've got probabilities and I've got all these sort of estimates, then I can do Monte Carlo simulation where I'm drawing from probability distributions and I'm generating synthetic data that says, here's what the uncertainty really looks like. And so here's a scatter plot of some treatment. It looks like it's very likely that it saves money and makes people better off. It's extremely likely that it falls below the line that I'm saying is the threshold, right? So this is very likely to be cost effective, right? Sometimes it's the probability that it's cost effective can be plotted against willingness to pay, and that's called an acceptability curve. So this says, well, if you're willing to pay a certain amount, then this will be cost effective with some probability, and not so much if you're willing to pay less. This is an interesting one that says, even if I don't care about health at all, willingness to pay is 0, then the treatment I'm evaluating would be considered cost effective. It's a 25% probability. Anybody guess what that might be? So I don't care about health. What do I care about? Money. There's a 25% chance it saves money. This, on the other extreme here, it says somewhere around, no matter how much I'm willing to pay, there's a 25% chance that it's not going to be cost effective. There's a 25% chance it doesn't work. It doesn't make people better off. So that's an extreme, that's a curve I made up to illustrate that point. But it goes, you know, basically you can plot saying, okay, against willingness to pay, what's the likelihood you would consider this to be cost effective? So those are different types of sensitivity analysis that we use to inform, you know, how, it's like, so here are these numbers. How solid do you think these numbers are, right? How happy are you with this recommendation? Then we're left with the question of what to do next, right? We've made a recommendation. I've said this is cost effective or it's not. Do this or don't do this. We've all gotten together and made that decision. But what if we're not very happy about it? I feel very uncertain about it. You make immediate decisions based on the best available information, right? The question remains, what's the value of obtaining more data? And that's a function of how much uncertainty is attached to the to what we've got? How sure are we of the inputs that we've used to estimate all these values? And how much does it matter if we're wrong? And what would it cost to find out? So that's bootstrapping cost effectiveness analysis into, do I want to study this more? Is it worth studying this more, right? Here's one that I'm getting ready to write a value of information paper. We just did the cost effectiveness analysis of screening for short cervix to prevent preterm delivery, right? And we're going, should it be universal screening, all pregnancies get 1 or 4 or whatever ultrasounds to be screened and then get treated. And it very much hangs on what's the effectiveness of progesterone to prevent preterm delivery. There were several studies that were out going, this is a no-brainer, we should be screening everyone. It's like, this is, some of them have backed off a little bit since they were first published and said, well, maybe we didn't consider, some things and this and that. So there's been some hedging. And then there was a big multinational study that was all over the place for the effectiveness of progesterone. The FDA looked at it and said, no, we're not going to approve this indication because the evidence is insufficient. We don't think it's very effective when you just look at the people in the United States. Now that threw away a lot of power, right? And ignored the fact that in a lot of other countries it was found to be hugely effective. So what was going on with that trial was interesting. But the next thing we want to do is saying, okay, well, right now we're not recommending universal screening, right? So only high-risk pregnancies are getting screened, or it's up to the OB, whatever they're doing is what they're doing, right? But we're recommending now that you don't screen people. That's the official FDA position, really, when you boil it down. And so I'm getting ready to say, we did the cost effectiveness analysis. We think that that there's a very non-trivial probability that the current guidelines are wrong. But there's insufficient evidence to say so. So we can use what we now know about the uncertainty around these to estimate what's the optimal trial to resolve the issue, to get us to the point where we're happy. And so we can use what's done in these models to say, I need a trial with 300 women in each arm over a 2-year period, and that would give me the power to say this is a real effect or it isn't. Here's where it would have to be in order for it to be cost effective, and we can find out if it truly is. And then so it's what's the value of that then in terms of down the line? If it really is something we should be doing, what is the value that we're giving up by not doing it over the next 10 or 15 years, right? All the pregnancies all the short preterm births that could be averted and all the costs and suffering attendant on that, what's all that worth compared to what the trial would cost to run? So that would give us an idea of the value of information. I think that this is one of those cases where the uncertainty is so great and that there's enough likelihood that we're really, really wrong that it's going to turn out to be a high priority research item. And we're in a position to propose that because none of us is qualified to do the research, so we're not tooting our own horn. I think that's okay. So how's all this used? Drug approval, but not in the U.S., right? The FDA does not consider cost. They just, if a drug has to be proven safe and effective, then they approve it. They can't consider cost. Medicare can't even negotiate drug costs, drug prices. They can't decide. They can't use cost to decide what to cover under Medicare. There is a group called the Medicare Payment Advisory Commission. It's a quasi-non-government organization that's advisory to Medicare. They can look at costs, and they have done this. I have to do a conflict of interest disclosure. I have research support from Amgen. But one of the places that Medicare has actually used cost is with respect to erythropoietin for people getting dialysis. That frequently people on dialysis get anemia, right? And you can either do transfusions or you can use erythropoietin. And they used to use erythropoietin to get them up to, let's really get their hematocrit up there. Let's get them really in good shape. Well, it turns out if you get them really in good shape, they tend to have heart attacks, and that's not a good thing. So now Medicare will pay for erythropoietin to get you up to low normal, right? But not beyond that. It cost Amgen billions. So they weren't really totally happy with that, but that's one decision. There was a decision about some sort of screening that everybody would have to join a registry in order to get screened, or it wouldn't be covered. So starting to look at cost a little bit. I think that down the line, the health system here is going to start looking at cost a lot more than it has. But anyway, drug approval, almost anywhere else, you got to show that it's cost effective, not just that it works, but that it's worth it. Determining benefits covered by insurance. So insurance companies do look at cost effectiveness in making decisions about coverage, sometimes what to cover, sometimes what sort of copays to impose. Like if there's, even from an insurance company's perspective, I'm going to probably subsidize vaccines, particularly influenza vaccine and the ones that really work, because it's going to save me money, right? Now, the government also subsidizes them. We really put a lot of money into vaccines so that people get them free or at very low cost, because we want the herd immunity. Prioritizing programs, right? So it's not, are we going to have, we were doing some work in juvenile mental health. There's school counseling, there's clinics, this sort of stuff, and there's juvenile justice system, right? Those are all involved in kids' mental health. We're not going to get rid of any of them, but where are we going to prioritize resources? Where is it best to spend the extra money that we get from this or that? Should we beef up counseling, more school nurses, or advising improved interventions in the juvenile justice system, these sort of things. So prioritizing does even get used in here, not much in treatment decisions. Physicians will not tend to be that interested in whether it's cost effective. They're interested in whether it's effective and what's in comparative effectiveness. But I think it takes a lot of extra thinking. Atul Gawande did one. He had a patient with cellulitis, and he thought it might be that really that flesh-eating staph kind of thing. And he treated the guy. It turned out to be it was, and he saved the guy's leg, right? Maybe his life. Then he went back and did the decision analysis problem. Took him a few days to work through it and all, but found out he should not have treated the guy. It wasn't cost effective because the probability was so low that was what it was. But he just had a gut feeling he did it. So interesting things. Doesn't work all the time. Getting there. Summing up. I think we're really good at comparing treatment options for a given circumstance. I think we can do that really well. We can do comparative effectiveness, and we can add in the cost component and say, okay, here you got a new blood thinner, is it worth it? Are you really that much better than aspirin? Okay. allows comparisons among treatments for different conditions. So I can look at different, I can compare an immunization program with a cancer screening program, but I'm not as certain about that comparison as I am about choosing among treatments that are similar, things that are similar. I can use this as a guide to decision making, but it's beyond my pay grade to say, oh, this is what you should do, right? I can say, here's the trade-off. Here's my best guess as to what the trade-offs are in terms of money, harm, and benefit when you're considering treatment options. But this rests on a set of assumptions that may not reflect every important concern in making choices in treatments and programs. Right? Have I mentioned equity anywhere in this discussion? Oh, so fairness is, economists are not trained to deeply consider fairness. But fairness is, I go, it's like, I'm all for fairness. But there can be trade-offs, all right? So some of the questions that you raised, is this a productive member of society, right? What's the value lost? People will try to hem and haw about that, but it's, I think it's a valid question. Saving young lives versus older lives, should there be more weight even given? It's like, when I'm doing all this discounting, right? If I'm discounting life years, right? Say, and right now we're supposed to discount at a discount rate of 3%. So that means that a life year 30 years from now is divided by 1.03 to the 30th power, which makes it almost nothing. So something that's going to prevent cancer 30 years from now gets very little weight. Public health types don't like that. Most of the stuff that we do, affects things at the margins, so they have to be pretty costly. They have to be be pretty effective and not terribly costly in order to be cost effective. If that's what they're doing. What else have I left out? Yes.
I have a couple of questions actually. So one question would be in places where you would consider drug cost effectiveness for approval. How is that relevant? You say drug cost is not static. So, when a drug comes out, it's very expensive, and 10 years later, it may be very cost effective.
Well, we'll cover it in 10 years.
So if the drug doesn't get approved now, and then of course all of this doesn't take into account, this is all population-based decision-making and not patient-based. So for a specific patient, that new drug might be more cost-effective because it's more effective than what we have that's cheaper but not effective for that patient.
So personalized medicine can be cost-effective, and so it's like, what does it cost to find out who will benefit the most? So there's a other set of costs coming. I do believe that particularly in what's developing in the realm of cancer treatment, where my understanding is what's evolving now, it's not even what the real site of the cancer is, but what is the cancer that's much more important. So there are, I believe, trials underway now that have multi-site cancers, but it's like this sort of histology or cellular behavior, what's driving the cancer is more important. And so in other words, genotyping the cancer and then targeting the treatment to that type of cell. So
is one drug much more cost effective for that person's cancer?
Right, and that can, and having that information can then make that decision, right? In the area of anticoagulation, there's genotyping there. Who's going to respond well to clopidogrel versus some of the more expensive ones? Some of the more expensive ones may be quite cost effective if you don't respond well to clopidogrel. epidural, and we can measure that. And so then there's a doctoral student over in biostats that's working on that for his dissertation, saying, is it cost effective, is the information worth what it costs to collect the information? And also then back to what you're saying, if we start collecting the information, the cost of collecting it will go down, right? You look at genotyping now versus 20 years ago.
When you start producing the drug, the cost of the drug goes down. Because if
Yes.
you start using in a select few patients, then the cost eventually decreases.
So, but yeah, you get into, we've got, I recently threw out one of my courses that I've taught for a long time, replaced it with a pharmacoecon class, which gets at what about what's the whole deal with patents and exclusive distribution and marketing restrictions and all the approval? What are the economic effects of all that? And then what about this? Okay, I can buy, what's the new hepatitis C drug? So anyway, we'll just say the new hepatitis C drug, and I can buy that for $100,000 here, and I can get the same course of treatment in Egypt for $900. And what it is, well, there's some cost of production that I have to get, right? But if I'm going to market this in the UK, I can get this price. I can get this price in Australia. I can get what the market will bear in the US, right? And as long as we don't allow people to re-import drugs, then I can do that sort of price discrimination and make the best money I can in all the different markets. That is a function of the way we have the system set up now, and that it's worth having a conversation. Is this the best way to do things? Best way in what sense? Yes.
So, very interesting talk. This morning when I was coming here, I was listening to NPR News. So they were talking about the third leading cause in the United States is because of medical mistakes. That would be the third leading cause of death here. Mm-hmm. But nobody has any record because either the case is settled with the patient family or the doctors are under oath not to speak about it. So how that cost, the settlement cost, is distributed here on all this?
So that is buried in the cost of care, right? So to the extent that mistakes generate more costs, then that does show up in the cost of care. The way that hospitals and other institutional providers of services are paid is based on their cost of doing business, right? And so typically you have prospective payment now for a hospital. You admit somebody with an MI and you treat them medically, well, you get paid a certain amount of money. And if they have other complications, other comorbidities, you might get a bit more, right? And there are geographic adjustments and all that kind of stuff. But if the average cost of care includes all the times that we've messed people up and generated more costs, well, that's buried in there. Teasing that out, getting more efficient is something that I think we should really work on. That I've got at least a couple of doctoral students that's their focus is on patient safety and getting all and running all this down, to err is human and all that. We've gotten better with, I think, infection control, particularly central line infections. I think we've done better there. There's a whole lot of other stuff, but yes. Those costs are all in there because somebody's paying for it.
But also spend on two other costs, so creating systems to try to avoid that is costly, and then also defensive medicine is costly. So, a lot of cost.
Yes. So yes, economists tend to work on the assumptions that everybody's doing things as optimally as they can, which is probably true, as optimally as they can, given the way things are all structured. But I think I think there's a good example in anesthesiology where they took a hard look at practices and did a lot of quality improvement, and now you have a lot less anesthesia-related complications from surgery than back in the day. there have been some successes, but I think that the health system needs a lot more industrial engineering.
Well, I guess physicians kind of need a huge amount of money. They make it so cost effective.
But yeah, there's a lot of value to be captured out there. I won't get off into the critiques of the healthcare system that we have, which are new.
So for countries where the average cost of healthcare per person is way lower than it is here, is that in any way the result of deliberate use of cost effectiveness analysis to make decisions, or is it different kinds of policies that have led to that?
Well, I mean, if that gets back to your budget constraint. And it's like for a lot of developing countries, when I have students that have a global health focus, and they tend to come to me with much more interesting cost effectiveness questions than I get in this. I mean, here I'm looking at, how do I improve the health of very well off people, who are willing to spend $150,000, for a minor improvement in their health, right? I'm going, yeah, I can do that. That's a lot more interesting in Ghana, mosquito nets, how much should we subsidize mosquito nets, or what should go into, should we allow GMO rice, that has vitamin A, or, all these sort of things. The cost effectiveness questions become very crucial when your healthcare budget is $300 per year per person. It's like, okay, well, now I have to really worry about maximizing what I get for that. So
I guess I was thinking more of things like, and maybe I'm basing this on incorrect assumptions, but a country like Germany and the United States, the amount of money that's spent on healthcare in Germany, I think, is much less than it is here.
yes, yes.
Is that what caused that?
Mostly, I'm willing to editorialize here. We pay a lot for drugs. We pay a lot for equipment, a lot for our salaries. Nurses make a lot more in the United States than they do in Germany. Doctors make a lot more in the United States than they do. So it's basically we have a huge industry that has not been afraid to use its political power to see that it keeps getting paid. So, so I would say that's what's driving costs. Now, there is the quality issue, and there's the how much stuff is paid for stuff that doesn't provide benefit is a great question. So I think we could continue to pay people pretty well if we would clean up things a bit, but at some point something's got to give. I heard Stein, an economist, that said unsustainable trends will not continue. So we will not reach a point where the entire GDP of the United States goes to healthcare, which is where we're headed if trends continue. But that means it's like, yeah, I was just at a meeting yesterday down in Montgomery looking at Medicaid, and Medicaid, the cost of the Medicaid program is projected to increase by a factor of 10 in the next 10 years, right? I'm going, it seems to be going down this year. And I don't think that's a good thing, but I'm going, it's like, okay, where do you get this? They're going, well, this is what the need will be. I'm going, okay, I understand that, but I don't think that need will necessarily be met. So, right. I think that was my last slide. Yes, good.
organization thinks about cost effectiveness really differently than an insurance company does. Is that correct to say, or is that?
I would say yes, that the, let's take a real staff model, HMO, Kaiser, or something like that. I mean, they're at risk. They eat the costs.
Right.
And
From your perspective, it makes more sense than that.
and people, yeah, and people stick around more. It's like, the folks that were in Kaiser